Okay. So this is an uber interesting case. This patient came to us, was referred to us. This is outside imaging. You can see a huge PE.
Mm-hmm.
I honestly don't know how patient presented to the outside hospital, but they were transferred with this big PE.
Mm-hmm.
And on the PE, they noticed, the liver is cirrhotic, and there's a lesion here, and then there were some sort of lesions there. So that's how the patient was transferred to us with this big PE and evaluation for liver mass.
Mm-hmm.
Okay. So as it comes, patient comes in, and of course they're short of breath and they're not feeling well, and you can see that patient is breathing all over the place. You can see there's a kind of a mass-like lesion here,
Mm-hmm.
and then more infiltrative appearance of kind of lesions in the right hepatic lobe, right?
Yeah.
So then the patient. So I didn't read this case, but the
Mm-hmm.
patient basically is sort of not able to hold still very well. You can see that arterial phase is pretty much non-diagnostic.
Right.
It's hard to know if there's, arterial phase hyperenhancement or not. So it's very hard to make heads or tails. I mean, the only thing that was kind of evident that the patient does have cirrhosis. So then
Mm-hmm.
we're talking about Lyrat situation here.
Mm-hmm.
So my colleagues brought this case to me and they said, well, uh, how would you report it?
Mm-hmm.
Clearly these are masses, but how do you
Mm-hmm.
report it? Do you assign a category? What do you do?
Mm-hmm.
And do you just assign category, non-categorizable, which is what happens when like the images are so bad that you really can't make heads or tails of it.
Right.
So the answer is, and this is the first teaching point, I guess, of the case, is that technically the LRNC, which is non-categorizable category, is reserved for cases where you, the images are so bad you can't even tell if the lesion is more likely to be benign or more likely to be malignant. So if you can't tell if something is more likely to be Laird's 1 or 2 versus 3, 4, 5M, then that's when you come, right? So technically that's not the case here. We're pretty confident to say that these are not benign.
Mm-hmm.
Although, with this degree of limitations, I think if LRM was given, I think that's understandable. And here's this hepatocellular phase. This is the only time in which she's actually held her breath. You can see again the mass,
Mm-hmm.
and then these big areas in the right hepatic lobe have kind of infiltrative appearance.
Yeah.
So, it was kind of reported as, not sort of diagnostic, but very, very suspicious for malignancy. And patient went for CT. So this I read the CT. So hold on. Okay, so we have arterial,
Mm-hmm.
and then we have venous, right? So we always want to have at least arterial and venous. Ideally, there's also delayed. We actually skip the delayed images for because of the radiation situation. But we'll start with this lesion in the right hepatic lobe. I'm
Yeah.
sorry, in the segment 2, right? You can see
Mm-hmm.
it's a mass, right? It's a
Sure.
clearly there's enhancement of
Yep.
arterial phase, clearly washout.
That's right.
This is over 2 centimeters, so this is slam dunk, Lyra's 5, definite HCC, no need to do anything else.
Mm-hmm.
So the question is, what are these things, right? So initial thought, and this is what they thought on MRI, is
Infiltrative.
that we're dealing with an infiltrative HCC,
Mm-hmm.
right? So, that's kind of where I was starting to go to. But then, like, something strikes me, right? So, if you can see that the vessels are kind of going through these areas undisturbed, right?
Mm-hmm.
Which is unusual for infiltrative HCC. Not impossible, but unusual. Another thing you notice is that notice how the capsule is preserved, enhancement of the capsule is preserved. There's really no disturbance of the contour or anything like that,
Mm-hmm.
right? And then check this out.
Yeah.
Patient has a
Yeah. That kidney thing.
very similar appearing lesion in the kidney. So
Mm-hmm.
in the kidney, I think we all agree that this looks like an infarct, right?
Mm-hmm.
So then I went back and said, wait a second, maybe these are infarcts.
Mm-hmm.
Maybe these are infarcts. So when you go back to MR,
Mm-hmm.
the kicker here, I think it's very cute,
Mm-hmm.
is that when you look at the high B value
Mm-hmm.
fusion weighted sequences, everything is kind of bright, including the
Yeah.
HCC, right? So that kind of is concerning for, again, for infiltrative tumor.
Mm-hmm.
But when you look at the ADC map, you can see that a
Hmm.
lot of these things are T2 shine through,
Yeah.
as opposed to
Mhm.
HCC, which is true diffusion restriction.
Mhm.
So I don't know why this patient has this kind of hypercoagulable state, but
Mhm.
she does because she presented with this massive PE,
Uh-huh.
and she has renal infarct. So this is our working diagnosis at this point, that she has a focal HCC, and then she has
Mhm.
these large infarcts in the right hepatic lobe, which kind of mimic infiltrative HCC in this case.
That's a
Pretty
really
cute.
good case. Like I've seen cases like that, like after liver transplant, where they have acute liver injury, for example, and that's what it
Right.
looks like. But it's usually after transplant. But this is a really,
Right. Right. So we don't generally think about liver infarcts because liver
yeah,
usually has dual supply, and but I guess
right.
she's cirrhotic. I guess she has some sort of she has a priori altered liver perfusion, and she clearly has hypercoagulable state. Anyway, I don't have slides for the cases, but it's just
Yeah.
a very unusual, interesting case.
Like when there's, is it like a microvascular thrombosis or is it like a gross thrombus like we see in the
Well,
PE,
we
for
don't. I
example?
didn't see
Yeah,
any
it was
any
patent.
thrombus. Right,
Yeah.
everything was patent. But
Yeah.
again, liver infarct is so uncommon. But I think I would assume that this is something on a micro whatever level, because again, the same thing is happening to the kidney.
Hmm.
And you can see like the same thing, right? The capsule enhancement is preserved over the renal infarct.
Hmm.
The same thing, the capsule enhancement is preserved over the liver infarct.
Hmm.
I don't know. It's a pretty cool case. I
Very
thought.
cool. This is a hard case. Very hard case. I
Right.
probably would have recommended like biopsy had I not really like I
Well,
got
I
scared
was
looking at
very
that.
very close to uh um to calling it infiltrative HCC, but then I think this kind of like, wait a second, this looks really really similar to what we see in the liver. I think that kind
Mhm.
of kicked my brain in the right direction.
I mean, the other thing, I mean, the patient's not doesn't have infection, right? Like doesn't have sepsis or any kind of
No, no,
bizarro.
they just came in. They just
I mean,
again they were transferred to us with this massive PE. I presume that
mhm,
she walked in with there's just a lot of shortness of breath,
mhm,
and then all of this is incidental. So
tough
it's
case.
possible that she's hypercoagulable because she has HCC,
Hmm.
but usually patients with cirrhosis are hyper. I mean the other way.
Hmm.
They're too coagulated. But not in this case.
Wow.
Another thing is cute. You can see like these corkscrew arteries, which is another cute finding in cirrhosis.